What's the most pressing question on your mind? Just ask, one question that you feel is, most pressing to you right now.
Okay, well, this one's kind of like a small one. This isn't school related, but this is just so I've seen this. I guess this is kind of bill related, but I've seen like people using toe touch variations as interventions to get for either depending on like where someone is sort of stuck, like put them into earlier propulsion or get lower posterior expansion. But like I don't understand. I don't know how to coach that, and because I feel like I'll try to do it, and it's like I almost just hinge at my low back, and I feel like that's not what you're looking for. You know what I mean?
Mm-hmm.
And I've tried to coach people on it too, and I just don't understand necessarily what you're looking for to coach it.
The things that I like to use it for is like I look at the forward bend as a pattern that's separate than the hip hinge, that's separate than the squat. But they kind of are on a continuum with each other, and it really depends on where people's starting point is to which one you want to go after first. I don't tend to look at it as like, oh, I need to restore IR, ER as much as like what pattern are they ready for? And the forward bend for a lot of people could come before a squat pattern because there's less of a mobility demand. I think there's less joints that have to be involved, but it really depends on what their symptoms are. So if you look at oftentimes one of the problems with the forward bend is that there's not a good posterior weight shift. So you can teach people how to posterior weight shift pretty well using a forward bend, and you can actually see a lot of improvement with the idea of getting the hips back, right? Getting the hips back behind the heels, which is part of a hip hinge, right? Like that's the beginning of a hip hinge. That's sort of the essence of the hip hinge. But to take that idea of shifting the hips back and then being able to bring the shoulders down while maintaining that posterior weight shift, that creates a lot of value for people, right? So that's one of the things I see as the biggest deficit with a forward bend too. If you're just asking someone to go down and touch their toes and they don't have any, tutelage on how to do that, they're usually going to shift a little bit forward and they'll like reach out in front of their feet instead of actually going down and shifting their hips back. So that's like the first thing I'm looking at is like, can you get somebody to just use that exercise as a way for them to understand posterior weight shifting? And I find that to be easier to do than to do the same thing with a squat or even a hinge, because there's this added benefit of like when you get down there and you are shifting, it's a comfortable stretch for a lot of people, right? And again, it's not about the stretch, but the stretch can be a reference for position that you're shifting in a way that you're not used to.
Okay. Yeah, that makes sense.
So like if you've ever seen the FMS version of like the toe touch progression, they'll use like heels elevated and then they'll use toes elevated. And the theme there is just different ways to get a posterior weight shift, but that has to be the process that you're looking for. In a way, or that's the intent that you're going for. So there has to be some cueing to stay back, because you can elevate someone's heels or you can elevate someone's toes and they still won't posterior weight shift just because they're not used to it. And then it actually can make the toe touch harder. But if you can teach that and use a heel elevation or even a toe elevation to promote that could be really valuable. Okay. And then I look at it as like, the squat then is sort of the opposite, right? So say you're doing a heels elevated squat and you're initially teaching a posterior weight shift, right, to get the heels back. So you can think of it as like a hingy squat. First thing you're doing is sending the hips back behind the heels, creating that same sense of, okay, stay back. Well, now instead of dropping the head and shoulders like you would do with the forward bend, you're dropping the ass, down towards the heels, right? So you're keeping the shoulders up, you're keeping the head elevated, but now you're dropping the hips, which while you're still keeping that posterior weight shift. So I a lot of times will use this squat with elevation and the forward bend as different tactics to teach posterior weight shifting, which I've found to have a lot of benefit for people. Okay. All right. And then the hip hinge is basically just the in-between, right? It's just the posterior weight shift portion, not trying to drop anything. It's just kind of just the back idea, like get your hips back, right? So I think hip hinging, and then if I want to do a forward bend or a toe touch, it's hip hinge to bringing my belly to my thighs type of idea, but have my hips go higher and my head and shoulders drop, where the squat is hip hinge, then drop down. Now that there's different ways to squat, but that would be for the intent of teaching that idea of posterior weight shifting, which is very valuable for a lot of people.
Okay, there's a lot of that makes a lot of sense. And then it's like almost in the squat, like it's almost instead of like a forward bend would be like hips go back, head comes forward, versus squat. I'm almost thinking of it like, I guess to start, it's more of a hip hinge, but then it's like your thorax and hips stay back, but then your knees will sort of go forward.
At a certain point, and it depends on how you teach it. So I think the posterior weight shift and the posterior tilt are also on the same continuum with each other. They're both versions of shifting your weight back, but they're just done in a different way, right? So for some people, posterior tilting is the way to go, like to promote that idea of maintain some essence of orienting your pelvis posteriorly, and then kind of dropping more straight down, right? So the idea of the squat where you keep your pelvis right under your rib cage, which, you know, there's a ton of value to, that is a version of keeping a posterior tilt in your pelvis or a posterior orientation relative to where it normally would go, and then sending your knees forward but still staying back through the heels. But I'll tell you, that's a lot more difficult to teach for people, and I don't see it as there's as much of a bang for the buck early on. I look at that type of teaching as a little bit down the line, but it really just depends on, you know, again, what you're focusing on, right? So that pattern though of trying to get more of a more vertical squat, like you're going to still try to stay posterior in your weight shifting, right? Like, so you'll still feel like the heel part of your foot without losing the front of your foot. You're trying to go away from an anterior orientation of the pelvis, but you're not sending the hips back in that hingy type of fashion. But both of them are versions of teaching somebody to get more posteriorly oriented. Does that make sense?
Yeah.
Right. So they both have a valuable intent. So even if you're teaching someone a quote unquote hingy squat, like that could be a very valuable thing early on because it's teaching people to get back, and then maintaining some posterior orientation of the pelvis and then dropping more straight down into a squat also is valuable, which will then have more of a knees forward orientation, but you still have to stay back through the feet. So that I think is like higher end for a lot of people. And then, but there's different drills for that would help people feel that compared to feeling the hingy posterior weight shift.
Right. That makes sense. And it goes back to what you said before with being further down the line, because you're just incorporating more joints into.
Yeah, in many ways. But I think it's a lot easier to to work around pain, to teach people to hinge and then drop. Like, so hinge, get your posterior weight shift and then drop into the squat, than it is to try to teach maintenance of a posterior orientation or a stacked orientation of rib cage over pelvis. Send the knees forward, but keep the heels back. Like, I think that's a little bit farther down the line for mobility purposes and also just coordination purposes. But it's certainly valuable. And I often, if I just want to work on someone's like ankles, or I want to teach them the top part of the squat, right? Like, I might just do that type of training where it's like maintain the posterior orientation, drop straight down, but I won't go full deep squat early on with that. I'll just teach them sort of like the top half, which go, from standing to as low as they can go before they basically lose that orientation. And then to get deeper, might go full posterior weight shift, like hingy squat, and then drop down to the bottom with heels elevation. But both, to me, work together because they're working on getting people away from being too anteriorly oriented.
Makes sense. Okay. Yeah, that's totally understandable. So my next one is kind of basically, like, we've been taught how to eval people a certain way. and it's obviously like it's different than, you know, what I've seen with you or John or anyone else I've shadowed. And I guess that's because I'm kind of in a little bubble here, but basically, like, how has your eval process changed since when you started out of school to where you are now?
Well, I think it's tough when you're in school because you don't have like an actual person in front of you to, you know, like just gauge their level of pain and all of the things that go into making people different, right? So you're getting a case study in front of you, but you're not really understanding like somebody, how sensitive they might be to movement, how what their background is with like how they may have been negatively affected by therapy in the past, right? Like, so you can get that early on from a person, and I find that that's certainly a bigger part of my assessment process now than it was earlier in my career. Just basically taking in somebody's story and listening for a while, just so I can get a sense of, okay, I can't be aggressive with this person, or I can be more aggressive, or it helps me know where to start just based on listening to someone talk and having their thought process about what they think they need. Because I don't want to just push on like my intention right away if I feel like that would be overwhelming. But if you get someone who seems like they're on the same page, or they're looking for that next piece of education that I think I can give them, then I'm going to be a little bit more aggressive. My physical assessment will be more aggressive, as well as the treatment earlier on. I mean, you still got to go through your movement screens, or movement assessments to just verify what you're thinking. But listening to people early on is such a huge part of knowing where to start. So it's never going to be the same in school because you don't have that right in front of you. So you don't get to listen to people talk for literally like 20, 30 minutes just about their history, right? And that's huge. And how they talk about it is even bigger than like what you might document on paper. Like, has a history of this, has a history of that. But like just how someone talks about it and the words that they use plays a huge role on their prognosis in many ways, but how you would want to start someone out. The other thing is, and this isn't necessarily something that I didn't get in school, but I would say I use this more now based on the continuing ed I've taken, is really just seeking out the things that provoke pain in a way that's very like systematic, or, you can tune it up, turn it down, trying to find the onset of symptom. That I find the most valuable thing to do because it becomes the most objective thing to compare to. So if you can find a movement that brings the onset of symptom, and you can really get the symptom behavior, like, okay, it comes on if I do several reps of this versus it comes on just even thinking about a movement. Like, that gives you so much more information that can be tested and retested over and over again, more so than trying to find a specific structural problem, right? It'll just be more like, all right, what is the direction of action that provokes your symptom, and what is the behavior of that provocation? Like, that's what I'm looking for. And a lot of it, that has become more of like a low-hanging fruit thing. But that's different for different people. And I don't think that's right or wrong. I think that's just how my brain tends to simplify things, where it's like, I want to find lowest hanging fruit, and then when I need to, I'll go deeper. But that lowest hanging fruit is what provokes pain within a movement. And then I will try to take that movement and break it down so that it's like somebody's doing a version that they feel ready for. So it's not so much based on joint by joint stuff. It's more based on like, all right, what part of this movement provokes your symptom? So now we can, do all these different things to work on that movement.
Would that change for you with acute versus chronic pain?
Yeah. I mean, acute, to a certain extent, I might be doing just a lot of assessment based on what somebody says, because it's really easy to over irritate somebody that's really acute. So I've had people that just, I barely get them moving, and I'm just like, you might be better with like an injection right now, like a steroid injection. Just experience has showed me that with certain cases, like especially real irritable nerve pain. that's going down an arm or going down a leg, and it's like within the first couple days, I'm like, there's not a lot that I can do for it. Like I might show people just some stuff distant from the symptom to just get moving, and maybe that helps, like some nerve gliding stuff. But most of the time it'll be like, let me just refer you out. I'm not going to do an assessment to try to provoke pain that's already there. It'll just be like, okay, you're too acute for me to be doing much right now. So yeah, it definitely matters. But there's still kind of an assessment just to find the movements that they can do without pain, if there are any. I think that's important, to just show people what they still can do as much as try to pinpoint what they have trouble with.
It's interesting. Like we were taught to, like part of the eval process would be to, I forget whose technical eval sort of process it's named after, but basically like you're gonna, like symptom provocation, you're gonna try to provoke something, but we were taught to do it in a way of like manual muscle testing, and it's like apply attention to an area, having fun. Like it's just interesting to hear the carryover there, because it's a different way of looking at it, but you're still sort of provoking symptoms to see what they can and can't do. But in your sense, it's more in a, like it's not as isolated of a movement, which I like, because it's like seeing how their body strategizes to do certain things. And like you said, like, is it the thought of something, or is it where in the specific movement? So that's
cool to hear. And it can be very specific. So I think it's good to have all of those different skills, right? So like doing manual muscle testing, we talked about this before, where it doesn't have to be the 0 out of 5 scale, but it's not a bad thing to learn that. It just, because it teaches you how to position people differently, how to respect, the relationship of gravity. And then there's sort of numbers that are thrown out there to make things more objective, which isn't a bad thing, but when you get lost in it, it can make other things confusing. So having just the idea that you now have this skill of manual muscle testing, and you can use that to provoke symptoms in a graded fashion, I think that's all I use manual muscle testing for. But I don't use it all the time, but I find if it's something that's useful to tell me the direction of resistance that provokes pain, now that gives me, again, like a low-hanging fruit type of information. So I have a patient right now who's got pretty irritable shoulder symptoms. So just using like manual resistive, I don't even want to call it exercise, but just manual resistive testing to find the direction that provokes her symptoms, or really just trying to find a direction that doesn't, because it seems like everything does. So if I can find a very specific angle of motion that provokes symptoms less or doesn't provoke it at all, that gives me a lot of information of what type of exercises to work with at this juncture of the treatment. But then also thinking like end game, well, I'm going to have to go to the other end of that spectrum at some point and still not have symptoms provoked, right? So then it's just giving me a direction based on where they are telling me that they have the least amount of symptoms. Right. And I think then like manual muscle testing turns into manual resistive exercises. It turns into all of these interventions that can be very specific when you need to be specific. But when you don't need to be specific, I don't think you need to start there. I think you can start with the thing that's closest to the thing they want to get back to, instead of starting, unnecessarily specific because we think we should. Because like I feel like there is an idea that if you're more specific with anatomy, you're somehow smarter, right? And what happens is you lose the whole body in that process sometimes, right? You should be able to go there, but you don't always want to start there. In my thought about it, you know what I mean? And I think like what I found with Bill's stuff was it actually made me start to think more specific again than I was, and to see how taking a bunch of specific measurements and then putting them together like on a chessboard idea can be valuable as well, right? Or very valuable. But you can't take any one for like anything on its own, right? Like or you're going to be limited if you do that. So I think there's different ways to do that. Like, I don't think you have to do that with specific range of motion all the time. I think you can do that with just getting a, kind of a library of norms in your head about what you expect different movement patterns to look like and what limitations indicate to you. And then have a process for trying to move them in a different direction. Right. And I'm trying not to use words like better or worse, but like use words more like in the direction away from symptoms, or in a direction closer to, postural control. And you know what I mean? But like everybody, you might be doing opposite things with some people just because their symptoms are telling you to at a certain point in therapy. So that's why I think like the symptom provocation is such a valuable thing. And that's where things like injury prevention get a little muddy for me, because if you don't have that symptom, now you're just making like assumptions about what everybody should do to prevent a symptom. And there's some value to that, as long as you have to define your why of saying like, why do I think like this is the best? And there's never going to be like a perfect, but it's like, if you have a why of saying like, why is it important to have your rib cage stacked over your pelvis? And you can have a discussion about that. I think that there's a lot of validity to, okay, maybe that's a starting point for us, right? Like, like from a postural control standpoint, and there's some reasons for it, but it's not going to be for everybody. And when there's a symptom involved, like, you don't have to worry about like a perfect posture. You just have to worry about like making someone move in a direction that's making their pain behave better.
So you tend to use, I guess, does it differ with, I'm sure it differs with like people who are coming in as physical therapy clients versus training clients, but do you tend to use more hands-off evals now? And is that, I'm assuming, like, did that change with quarantine because you were all online for a while with it?
Well, yeah, it certainly pushed me more in that direction, but because of the way that my business has become like this hybrid thing of training and therapy, I've found that I've gotten a lot better at using the, kind of more global approach of assessment to help even with the physical therapy type population. And I haven't had that many Zoom physical therapy evals. I've had a couple, but even when I'm getting people coming in, like I might put them on the table for a little bit, but it's pretty clear when you hear somebody say like, oh, I have trouble with walking, or I have trouble like sitting. It's like, you got to work on those things anyway. So I'd like to start with like, what do you struggle with if I break down those movements, instead of like, what specific joint range of motion are you limited with? I mean, we'll eventually get there, but like if I have an hour with someone and I want to get them started with a home exercise program, a lot of times, like I want to get them started with some position or transition that is within the movement that they're limited with. Right. So, and I have, like a Rolodex in my head of things like, this is probably going to be like a starting point. So I don't often need early on to get every joint angle. That's just, it doesn't tend to help me. I think it might help someone else. And, I've gone through a lot of different models, and it's just like, even when I've gone through those models, like trying to get too specific early on doesn't tend to help me that much. But having the understanding of the relationships from head to toe in the body from those different models, that's huge. And then it actually makes the more global assessments easier to understand and to know what to look for, know what to get people started with.
It sort of goes back to like, you don't have to start that specific.
Yeah, it's up to how your brain works, like your history of your causes and conditions, right? You can go either way, and it's nice to be able to go either way. So when you're in school, it's like, maybe it's just easier to teach from specific out. And maybe like, because that's how I got taught in school, like I like it the other way now. You know what I mean? Maybe it's some type of resistance but I don't know. It's both are important. And then you kind of find what works for you. I think it makes sense to me to talk to people and work with people in movements that they actually care about, and more than trying to get specific. But I'll tell you, like, there's more and more people now that they have an idea of what physical therapy is. So they come in with like this specific mentality about anatomy and diagnosis that's actually way more specific than mine. And I have to balance that. And sometimes I have to go more specific than I normally would, just because that's what people are looking for. And I have to speak in like anatomy jargon that I think is not actually accurate to their problem, but just because that's what they're looking for. So, you know, you have to be flexible. So that's why you just want to know things from both sides so that you could pick, you know, what works for that patient.